Hey YouTube, it's Marita. Welcome to another edition of the Nurse Lounge. And in this edition, we are going to do a Q&A postpartum edition. You want to see what questions people have asked me? Stay tuned. All right, so we are back. We are going to do a Q&A postpartum edition. These are some questions that you YouTubers have asked me regarding postpartum care, or not care, but being a postpartum nurse. And I wanted to kind of basically just answer those questions here. It was easier, or it is easier for me to answer those questions here than it is to type out my responses. Plus, being that so many people are having interest in postpartum care, or not care, but being a nurse, I definitely wanted to go ahead and answer these questions so that I can put a whole video out so people could see, and that way I could have them go see those other videos if they were interested in them. So we're gonna jump right in. There's only 3 questions, but the questions are loaded questions, and basically that they were excellent questions, and I really wanted to answer these questions for them, as well as anybody else who may be having these same questions or concerns regarding becoming a postpartum nurse or how to deal with certain situations in the postpartum realm. So I have my phone here. You're going to see me look at my phone to read these questions to you all, and then I will be answering the questions. So the first question comes from a male, okay, a male nurse. So, or I don't know if he's actually a nurse or not, but he may not be a nurse. I don't know if he's still in nursing school, but either way, he's going to be a nurse. And so he says, any tips for men going into OB? He says, the reason why I ask is because I had some awkward moments during my clinical rotations. However, I really enjoyed OB a lot, more than I anticipated. I did run into a few hesitant female clients and a few what appeared to be, in parentheses, jealous or upset husbands/boyfriends, but I enjoyed my rotation regardless. He has an interview, the next day, so he is actually about to finish school, and nervous but hopeful. He said, we shall see. Thanks for this video. So, excellent question. Excellent question. So we typically don't see a whole lot of males who truly have an interest in OB, only because of the fact that the nature of what OB really is, in terms of having babies and things like that. And I have worked with one male in my nursing career who, you know, he was just one of the girls in my mind after a while. But he was an excellent nurse, and he actually did postpartum, and he did well baby nursery, and he did a great job taking care of his patients. And so now I'm going to answer these questions. He said, any tips for men going into OB? I basically think that you need to just remain professional. And if you mentally think of it, I'm going to tell you what I tell my students. So OB is just or postpartum specifically, is basically a specialized med surge. So with that being said, that means we only care for women, but it's a specialized med surge. It's basically med surge except for specialized. So we only care for women, obviously having babies. And that's the gist of what we do. But with that being said, if you maintain professionalism, there's not any issues. Having a female in OB is no different than having a female in the ER, ICU, med surge, step down, or anywhere else you may have a female patient. Professionalism is the key. Now, there are some concerns or issues? Sometimes we have religious preferences where they are, by religion, are not allowed to have male nurses or male doctors. Well, in any situation like that, we would just have to honor their requests or their wishes, and you would not be able to work with that patient in that situation. But generally speaking, there's no issues with a male working in OB. So if that's where you want to be, definitely go in and do so. Now, when he mentioned about the he wanted to know other tips. The only other tip that I have besides remaining professional and doing your job would be when you actually go to knock into go into your patient's room. We have a male, he does the hearing screens for our babies. And he's a male. And the nurse, who obviously was a male, what he would do when he walked into patients' rooms, he would knock on the door and say, my name is, I'll be taking care of you today, from the door. And then that's his first introduction. Then after that, he would say, "Are you decent?" Those were his words. And that is the other person's words as well. "Are you decent?" Meaning that, are you dressed in an appropriate manner where you're covered? If you're breastfeeding, either he'll come back, or if he's not gonna able to come back, then he will ask you if you're decent. And that is your cue, the patient's cue, to go ahead and cover up or anything like that. So those are the biggest things that I would say do, is basically maintain professionalism. Knock on the door, as we all should be doing. All nurses should be knocking on doors. We just don't walk into patient's room. Knock on doors and, basically introduce yourself, address yourself, who you are. And in their situation, they ask, are they decent? I'm about to come in. I need to come in and check you for whatever it happens to be. So hopefully that answers that question. And then his other question was, he has run into a few hesitant clients, and a few jealous, upset husbands or boyfriends. So, that's the nature of the business. I feel that for women in general, when they have a male nurse, sometimes they're put off by it. In OB, they're put off by it sometimes because they're like, I'm not sure about this. But unless they are victims of rape, which we do have those situations, rape, molestation, things that are just not favorable, then maybe in that case, as well as the first case I was talking to you about religious preferences, you should not be the nurse for that patient. Because it can bring up triggers. And even for myself, being a female postpartum nurse, anytime I'm about to touch a patient, when I'm doing my head-to-toe assessment, I always say what I'm about to do next before I put my hands there. So as you all, or if you don't know, in postpartum, we do have to go into the, what they're called, the peri area, basically the vaginal area, and basically kind of inspect and see what's going on down there, see if there's any trauma down there from the baby coming out. We have to check their bleeding and things like that. So very intimate, private parts of a woman's body. And with that being said, we do have people who are victims of rape, or maybe they've had situations in the past where something that was just not favorable, touched inappropriately. So therefore, I always make sure, for me, even personally, I always make sure that I always address what I'm about to do before I do it. So when I come in, I walk into my patient's room and I say, my name is Marita, I'll be taking care of you today. We're gonna do your vital signs, and then we're gonna go ahead and do your assessment. And I basically say, I'm gonna listen to your heart, lungs, bowel sounds. I'm gonna check your pad, check your vaginal area, check your bottom for hemorrhoids and things like that, and then work my way down. But as I'm going through those steps, we check their breast as well. But as I'm going through those steps, I actually say, okay, now I'm about to check this. So when I'm listening to the heart sounds, I say, I'm listening to your heart. I'm listening to your lungs. I'm listening to your bowel sounds. I am now about to check your pad. So I give them warning that I'm about to check their pad, or that I'm about to do this, that, and the other. If I'm looking for hemorrhoids in the back, I said, okay, now I'm about to touch your bottom because I'm about to look for hemorrhoids. So they are knowing what I'm about to do before I start touching them. And I do that even as a female nurse because of the fact that I know some of my patients, and I do this for everyone because I don't know, some people don't disclose that they've had a history of rape or abuse. So I do that to everyone. I make sure that everyone that I touch, that she knows that I'm about to touch something before I actually touch it. So therefore it doesn't come off guard to her, and she gets startled by it or reacts to it. I do have a story real quick about something along those lines, and it may help some of you as well. I had a patient who was a victim of rape. She's had about 5 kids, but she was a victim of rape. And it was something about putting in that catheter that really, brought the PTSD. It came back. And so the orders were to put in a catheter for her to go to get some procedure done. And it took literally 30 minutes for me to even try to get it in. And it got to the point where she screamed and hollered so much. And the thing is, I never even touched her with a catheter. I couldn't have her keep her legs open long enough to get the catheter in, and that was the problem. I brought in 3 other nurses. One nurse was a distractor nurse. The other nurse was holding the leg back. The other nurse that was the other nurse trying to get the catheter in. And so even as I'm swabbing to clean the perineal area and around the urethra, she's just coming unglued. So in that situation, I was like, you know what? this feels like I'm doing the exact same thing that that perpetrator did to her, and I'm not doing it. So I called the doctor and I said, I'm sorry. It took about 40 minutes for me to even try to get to this point. She is not allowing me to get that catheter in. I refuse to do it at this point. If you want to come and put the catheter in, that's up to you. But I feel like I was doing the same thing to her that that person had did to her, because she was crying and she was yelling and she was screaming. I will not do that. So I made a conscious decision at that point in time that I'm not going to do this, and the doctor had to come in and do whatever they had to do. It ended up she didn't get the catheter anyway. They found another way to work around it. But that's kind of my point. You know, we have people who are victims of rape who've been touched and traumatized and things like that. And even though she's had 5 babies, which means she's gotten pregnant 5 times, which means she's had intercourse at least 5 times, still certain things bring triggers for certain people. So just be mindful of that, you know, even as a female nurse, I have to be kind of touchy when it comes to those kind of situations. So as a male nurse, I know you definitely would have a difficult time, but we do have male doctors, right? So since we have male doctors, there's nothing wrong with having a male nurse in OB. You just maintain professionalism and you'll be fine. And then when you mentioned about dealing with the jealousies and the things like that from boyfriends and husbands, or how they kind of react, again, maintain professionalism. But if you're a handsome man, you can't help that. You just can't help that. And to be honest with you, I've had the exact same situation when it comes to the husbands, boyfriends, so to speak, from the patient side. So I've been fired from a patient's room, not because of the fact that I did something wrong, but they were basically an interracial couple. And not that that has anything to do with it per se, but her boyfriend was very flirtatious. And any nurse that walked in there, myself included, you know, if you halfway looking decent, he was just trying to talk to you, trying to holler at you. And she knew that. And so she fired every nurse that came in, so nobody could really care for her, except for the, I wouldn't say call her Ugly Betty nurse, but the nurse who she thought was okay was the one who was definitely not the most attractive, I guess, and definitely her boyfriend wouldn't be, you know, interested in. So you will have those situations where you are going to attract the boyfriends, girlfriends, or whatever it happens to be of whoever you're dealing with. But you just have to maintain professionalism and just kind of keep it moving. I've been approached by some of these husbands or boyfriends in the hallway. So they'll come out the patient's room, their girlfriend or wife's room, and be flirtatious. And I'm like, no. Well, first of all, no. And second of all, you just had a baby. And if you already cheating on her by flirting and trying to talk to me at the nurse's station, what the hell did I want with you? What do I want with you? You know, why would I want somebody like that? So just be mindful that that's what they do sometimes. So I would say when it comes to OB specifically, for a man, if you are having issues with their husbands being jealous or whatever because you're doing this, that, and the other, that means they have an issue, not you. Just remember that. They have an issue. They have some insecurities that they need to deal with, and it has nothing to do with you. And that's one thing that I've had to tell myself. If the wife or girlfriend is jealous because the husband is acting inappropriate, you all have issues with your relationship. It has nothing to do with me and how I look or whatever it happens to be. Same thing with you as a male nurse. If you have any issues or concerns about certain things, or you feel like you need to change assignments because it's becoming to be a bit much, then feel free to change assignments. Go to your charge nurse and simply say, hey, I'm having a situation here, and the husband or the baby's daddy is you know, kind of giving me a hard time or whatever, and it's okay if I change patients. And if they say yes and you can do it, do it. If no, just keep it moving. Just like, you know what, maintain professionalism, cluster your care, get as much done as you possibly can. Definitely interact with the father, or, you know, the father or husband, boyfriend, whatever happens to be. Interact with him. Sometimes if you actually exchange conversations with him, it kind of eases what's going on with how he's feeling about the about you interacting with the mom or the patient. Also, I find that when it comes to situations like that, I try to get at their level, find something they're interested in. I live close to a military town, so we have a lot of soldiers around here. So, you know, I kind of talk to them about, oh, okay, what rank are you? What do you do in the army or whatever it happens to be? And that way I engage the man for me. And then also, not for me in that sense, but engage the man in terms of conversation with me to get him, you know, to not be as distracted about whatever happens to be. Or you know what? There's always a football game, baseball game, basketball game on if the man's in the room typically. So I'm like, oh, okay, who's playing today? What's going on? Where are we at in the playoffs or where are we at? Whatever. I engage the man like that. So that way he feels like he's part of the conversation. He's included. And a lot of times in OB specifically, the men get jealous, not because of you per se, because all the mother is getting all of the attention. The mother and the baby is getting all the attention. And he feels like, okay, so am I just here? So I find that when I interact or engage with the father, that he feels included. So when I'm changing the diaper, I'm like, okay, of the baby, I'll say, okay, hey, have you changed the diaper before? Let me show you how to change a diaper. Or, you know, he'll say, when I'm feeling her fundus, he'll say, what are you feeling for? And I say, oh, I'm feeling for this right here. You see how hard it feels? And I'll have him put his hand there so he can feel how hard it feels. And that's what I'm trying to basically get for it to stay that way. And so he feels like he's engaged and he is actually a part of her care, and he, you know, he's more caring. So I try to basically create a distraction, divert the attention from me back onto the mom. But then you have situations where some of these people, they just trifling. I'd have met some trifling patients, and I'd have met some trifling spouses, boyfriends, significant others, baby daddies, whatever you want to call them. So just be mindful, be professional at all times, engage if you can. If not, just cluster your care, keep it moving, and you'll be fine. All right, so hopefully that answered his questions. Then we're gonna move on to my other question that I had. And this is by someone who says, I'm graduating in May and I hope to go into OB. I have 2 questions. She says, one, in school and during clinicals, one thing I've never heard about as much is how to help out, not medically, but emotionally, the mother that has delivered and lost her baby dead. Basically, the baby was stillborn. My question is, as a nurse, what have you seen as the best way to handle the situation? And then I'll go to her second question. So the question was, she wants to know how to help moms, not medically, but emotionally, after they have delivered and lost their baby. So I don't know if she means stillborn, the baby was already deceased, so it was a stillborn, or the baby was born alive and died after. But I guess either way, the answer would be pretty much the same. So I have had this situation happen in plenty of times. This is the part that I say about OB. OB is not what you all think it is. People think it's such a happy place all the time, and it is not. We have so many people, we call those fetal demises actually. And just like with any death, and if you're in the spiritual world at all, deaths comes in 3s a lot of times. So we happen to see, you know, we'll have a period of time where we have no fetal demises, and the next thing you know, boom, 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 we have 3 in a row, very close together, usually within days to months of each other. And then we go on a hiatus, and then boom, boom, boom. True story, I had a patient come in who she was scheduled to have her C-section that day. Scheduled to have her C-section that day. And so she came in, they had already did the baby shower. She was excited. The room's already set up back at home. She's gonna have a little girl. And when they get her hooked up, so she's just coming in that morning to be, to deliver her baby, to have a C-section. And so when they come in to do so, they hook her up onto the xoxo monitor and everything, and they got no heartbeat. And, you know, they got an ultrasound done, and they confirmed the baby had passed. Now, when the baby had passed, that part I don't know, but the baby had passed. Now, mind you, she's coming in for a C-section, so she's full term. So she was about 39 weeks or 40 weeks or so, full term baby. And the sad part was her first baby. Well, it would have been sad if it had been her 10th baby, but I'm saying it was her first baby. And because she had to have a C-section in her situation, she's going to have that scar to remind her day in and day out on her lower abdomen that she had this baby, but then she doesn't have the baby to bring home. So to answer this person's question, basically what we do is we try to, in terms of emotionally, we actually try to keep them in L&D as long as we can. And if you're delivered vaginally, so if you come up the natural route, the baby comes up the natural route, we let you stay in L&D until you're ready to go home. And typically, if you've had a baby, say today, and the baby was stillborn, when you are medically cleared to go home, usually that same day, they will discharge you from L&D. They don't send you to postpartum. If your bleeding is fine and everything's okay, they will send you home from over there. And while you are over there, you are allowed to hold your baby to, they will get you a grief packet together where they will sometimes cut baby's hair. They will do handprints, fingerprints. They will give you the baby's bracelets. They will dress the baby for you. They will put the hat and stuff on for the baby. They will take pictures and at least we create a book for you, a grief book, so that you can look back at the pictures of the baby and go through whatever you need to go through. But actually in the hospital setting, we actually do encourage moms to hold their baby after they have delivered this baby that has now deceased. And we typically let them hold the baby as long as they want to, and then see the baby as often as they want to, meaning that they see the baby and sometimes they're ready for the baby to go back to the morgue, and then they decide they want to see the baby again, and we go get the baby, or we'll call for them to bring the baby back up from the morgue and for mom to hold the baby and things like that again. And we typically allow that to happen every time that she wants to happen until really the baby has begun to change in terms of the molting and rigor mortis and things like that have set in. And if she's adamant about still seeing the baby, then we still allow her to see the baby. We just have to warn her that the baby's color has changed to this point, that the baby is looking, a little bit more, well, I mean, just, it's not looking like a regular newborn baby at this point in time. So we prepare them for that. We have had one situation, typically though, when you have to go to postpartum. So in the case of that C-section, she had to come to postpartum because she had to still deliver the baby via C-section. It wasn't where she could just push the baby out. It's not where they could just, not let the baby come out. The baby had to come out, and it had to come out via C-section because she was full term. So she had to have the C-section still. And what was heartbreaking about her situation specifically is that she's coming over from labor and delivery, from having the C-section to postpartum. And as a result of that, she has to be on the floor with other moms who have babies. And we had tried to get her put on another floor, like a 5th floor, which is our med-surg floor. But the doctor refused to let her go there. So we had to bring her to our floor, or keep her on our floor. And what we basically did was put her away from other moms. So we have an area in which it's kind of like our overflow area. So we put her back there by herself. And I know that sounds kind of like, well, how'd you put her by herself? You really don't realize when you hear other babies crying around you and realize you don't have yours, that it kind of sets you into a frenzy, a fit, if you will. So for her mental stability, we put her away from other moms so she's not hearing babies, crying and things like that, knowing that she doesn't have hers. We check on those patients more often than we check on our patients often anyway, but for her, we have to check on her more often than the average person, because I want to make sure that she's okay. I definitely encourage them to talk if they're wanting to talk. If they're wanting to not talk and just cry, we encourage them to do so. I personally feel that crying is a great release. I even talk to them about grief counseling when they are ready. I tell my patients that crying in the shower is a great place to cry. Because of the fact that you're by yourself, you can kind of break down and you don't have to worry about people telling you, oh, don't cry, things like that. I feel like you really need to get that out as often as you need to. So I tell people, cry in the shower, go in the shower, take your shower. So you don't even need a shower, but go in the shower and just release and have your screaming session, your punching session, your crying, do whatever you need to do, because that's part of the healing process. And then in addition to that, I call case management and we see about getting her some grief counseling outside of the hospital. So those are the biggest things that we do. And also we try not to make sure that we give that patient a nurse who is pregnant. So that you typically go through a period of time in which you go through those stages of grief. So you're angry, you're very angry, you go through denial, you just go through all those processes. And so during that anger period of time, a lot of times you have a situation where you're like, okay, why is it that they get to keep their baby and I don't have my baby? You may have not did anything wrong with your pregnancy, but something happened where the baby just passed, where we have these other moms who they did drugs and the baby comes out fine. Well, I wouldn't say fine, but the baby comes out alive anyway. And so, and able to go home. And so it's very disheartening when you have those situations where you've prepared, you've wanted this for so long, and it finally comes to fruition, so you think, and the baby ends up passing away. So that's the biggest things that I do. I definitely just talk to my patient a lot. I allow her to talk about what she wants to talk about. If she doesn't want to talk about it, I don't bring it up. But at some point I will say, okay, hey, how are you doing? How are you feeling? And I just, if I happen to know another nurse who has been through what she's been through, who is willing to talk and she's willing to listen, then I will actually have that nurse paired with her, and they can, you know, they can say, I know what you've been through, and kind of talk. And sometimes it helps to know what someone's been through and to know how they came out the other end for it to help them. Now, mind you, with these kind of patients, we in the hospital don't follow up, but that's why case management is involved, so they can follow up and see what's going on. And then hopefully if something goes on where we need to get some type of counseling, some type of intervention. We do depression scales on our floor for all our patients, so we kind of monitor that as well with our patients on the depression scale to see kind of how they're doing. And we intervene based off of that. So emotionally, it's very hard to have a patient who has lost their baby. And then, like I said, we try not to pair them with nurses who are pregnant. And that's pretty much it. I just try to make sure that we're compassionate. I try to make sure that in some cases, if I can, I save her for last, because I know in terms of when I have her as a patient, I may have 5 other patients and she's my 6th patient. I purposely want to make sure I give her the time and attention that she needs. I want to make sure that she's properly medicated, meaning that if she's in pain, I want to make sure her pain needs are taken care of. I want to make sure that her if she needs to eat. Believe it or not, sometimes when you're depressed like that, you don't want to eat. So I always make sure that I try to, you know, encourage them to eat, even just a little bit, just to eat to, you know, they have, their body still has to heal from this whole process of having the baby. So I want to make sure that they heal and kind of do, you know, what they need to do to heal. It's a daunting process. It really is a daunting process. It's very difficult. It is emotionally draining for the nurse as well. If you have any compassion or any empathy at all, it is emotionally draining for the nurse as well to have a patient like that, because we've had patients who are screaming, who are crying, who, you know, I mean, I say screaming, I mean, they're screaming. The other patients can hear them screaming because they're going through so much with this loss. And so you're trying to comfort them while you're trying to care for your other patients, and you're trying to care for your this patient. So it is very, 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 very difficult, but it's something that is very necessary to do to make sure you provide compassion and provide great care for that patient. All right, her last question was, she said, do patients typically have hesitation or give pushback to nurses that may not have kids yet when it comes to providing them education? I would say that having kids is beneficial, obviously, because you've been there, done that. But I don't even think patients even care. Most of them, they don't even know if you have kids or not, because it doesn't come up per se in conversation. Now, well, it does. That's a lie. It does come up in conversation quite a bit for me. I look younger than what I am, so I've had plenty of times where a family member has said, no, I don't know, you know, and they're joking. I don't know, I want you taking care of my baby because you don't look like you're old enough to know anything about no baby. And like, I have 4 kids, and my oldest one is 20. So since my oldest one is 20, I think I'm well versed on how to care for babies. I've been doing it for over 20 years. And I have, you know, and I tell them I have a, you know, 20-year-old, an 18-year-old, how old is he? He's 9, and then the baby is 6. So I have girls, I have boys, I have everything. I have a special needs child. So I got a little bit of everything. I know how to care for children. And so for me, I will say it has come up. And once I say all of that, they don't say nothing else about it. But I would say for the most part, there's a lot of nurses who don't have children, who they just know to provide research-based, evidence-based practice education to their patients, and that's what the patients have to go with. So when we print our discharge paperwork out, it has all the information on there. We teach the same thing that's on that paperwork. So they have something to verify that this is what they're supposed to know. I will say, though, having children already, it does kind of foster that relationship with the patient, build rapport with the patient, making it where, you know, when I go into my patient's room and say, oh, how are you feeling? They're like, oh, I'm tired. That is their cue to me that they want me to get in, get out, and leave them alone so they can rest. And I said, oh, okay, I definitely understand. You know, I definitely understand that. I said, then I'll say, this is what we're going to do today. And I kind of get my assessments and everything done, pass my meds and vital signs, and get everything done. But they kind of do, they kind of feel like, oh, okay, she has children, so she understands. But it's not a conversation that comes up, but you don't have any kids, you can't talk to me, you don't know what you're talking about. Have we had patients like that? I'm sure we have. I'm quite sure we have. We've had that, you know, the stickler where like, you don't have, what can you tell me? You don't know. I haven't had the experience because I have kids, but I've met some nurses who've had that experience where they said, well, I don't know if I'm going to be good on this floor or not because I haven't had any children. Okay, think about this. If you're a med surg nurse and if you've never had a heart attack before, Does that mean you can't educate them on how to care for themselves after having a heart attack, or what the disease process to having a heart attack is? No, it doesn't mean that at all, just because you haven't experienced it. So as long as you're giving evidence-based practice, evidence-based research as form as your education, not just some hearsay, not what Wikipedia said, not what your mama and them said, then you are good to go. Because I haven't had a lot of disease processes. I have had hypertension with pregnancy, so I know what that's about, but I have not had a heart attack. I've not had a stroke, praise God. I've not had any of these things, but that doesn't mean I can't teach you as a patient about what that means, what it entails, and how to care for yourself. So hopefully that answers these questions that you have all asked. I apologize. Well, actually, I don't apologize. The video is about 30 minutes long or so. It is what it is. That's why I said I really wanted to have a video to kind of explain these things, because it was just too much to type out, and not for them to not understand what I was trying to convey in my message and typing it out. So I definitely want to do a video, and I will always do this. So if I get a few questions regarding OB or nursing or something like that, I will just put a video together real quick and answer those questions, just because that way it's something that people can come back to it in the future, or come back to, and basically look up and see what did I say about that issue. And plus, everybody doesn't watch the same video. So the videos in which those questions were asked, if I answer them there and no one goes to watch those videos, you're going to ask me the same questions again. So therefore, I feel like let's just go make a video on this, and that's what I'll continue to do. So as I get questions in, 2 or 3 questions at a time, I will definitely come and make a video on those questions. That way it answers the questions for everyone, and you all can definitely read those or watch those videos and hear what I have to say about those. So these were some very, very, very good questions. I really appreciate you too for asking those questions. If you all have any questions, please ask them down below, and I will create another video for you just to answer those questions for you. If you happen to like videos like these Q&As, definitely thumbs this video up. If you are new to the Nurse Lounge, welcome. Thank you for coming by. Definitely subscribe if you have not already. If you are old and you keep coming back but you haven't subscribed, what are you waiting for? You might as well just go ahead and subscribe. It's a little bit here for everyone. So if you happen to like nursing, this is a nursing primarily channel. If you happen to like nursing, then definitely subscribe. I have something for current nurses, new nurses, future nurses, second career people who want to be nurses. I am a registered nurse for almost 15 years. In the next couple of months, it'll be 15 years for me as a registered nurse. OB, GYN nursery is my specialty. I'm also a nurse educator, so I teach LPN students, 2-year RN students, and 4-year RN students. And I do case management, which I've never mentioned before, but I do case management for one of my jobs. And also, I am on my DNP journey. So I have my master's degree in nursing education already. I am not a nurse practitioner. I'm a nurse educator. I have my master's degree in nursing education, and I am currently pursuing my doctoral of nursing practice degree, which I'll be finished in May of 2020. There's a couple of videos on that, and I will actually create more in the near future. So if you like this, subscribe. There's not a reason for you to not subscribe. So until the next time, you all take care. Bye-bye.